judged.
Everybody's here. We're going to be talking about malignant hyperthermia. And I've got a presentation that's courtesy of the Malignant Hyperthermia Association of the United States, MHAUS. And some of it is pertinent for us, and some of it we're going to skip over here. We're also recording this so that we can make a YouTube video. Be sure to like it. I'm trying to get 1 million likes on this one. Anyway, MH is a very weird disease, especially if you're not an anesthesia provider, because it seems like it was tailor-made just to give us trouble in the operating room. It is defined as an inherited disorder of muscle triggered by anesthetic agents and causing this hypermetabolic crisis. What it really means is that it is a subclinical muscle disorder, meaning that most of the people who are susceptible don't know it. They're just walking around having normal lives until they're exposed to certain anesthetic agents. It also means that it causes the muscles to act as if you are running a marathon. They are hypermetabolic, generating heat and a lot of waste products, even though you might not actually see any muscle activity. This slide basically demonstrates two things. First, there are only 2 triggering agents. One is succinylcholine, and the other is volatile anesthetic agents, the stuff that we have in those vaporizers there. The other part is stuff that does not trigger MH, which is everything else. Okay? So you can see that it's actually fairly easy to deliver an anesthetic without using triggering agents, and that's something that we would do if we have somebody who's suspected of having malignant hyperthermia. This is a very busy slide, but essentially, you see that the anesthetic agents cause a derangement of skeletal muscle, which does a couple things. Sometimes you see a contracture, but not always. You see a hypermetabolic state, which causes most of the problems, and then you see muscle breakdown occurring. All of these go, you see on the bottom of the slide, you see renal failure, cardiac arrhythmias, and cerebral damage. I mean, this is where bad things happen, and if untreated, it has a very high mortality rate. I think it was like 80% back before we discovered that dantrolene is a very specific antidote for this. As a result, the mortality from an MH event is under 5% currently. Okay. This slide says that the prevalence of MH is about 1 in 5,000 to 1 in 10,000 people. This is not how many incidents we have, but how many people are MH susceptible. We're not 100% sure. Kids seem to have a higher prevalence than adults. But if you run through the numbers, 1 in 5,000, we might do maybe 5,000 cases here in a year. So it doesn't sound like we have that much of a problem here, that 1 case per year. That being said, there have been at least 5 patients who have come to our ORs with known malignant hyperthermia. And there is a family that lives in the area that is MH susceptible and gets their care here. So there are certain hot spots, and I think we can add East Norriton to one of those areas, because we do see more than usual as far as MH susceptible patients.
So it's familiar?
Yes, yeah,
So
exactly.
if I have it, my daughter will have it, or you just assume that?
It's autosomal dominant, meaning that your children would have a 50-50 chance of having it.
So you would treat them as if they would? Or
We would
test them?
both. We would test them, and then either there are some people who if somebody tests negative but has a family history, would you still give them a non-triggering anesthetic? And there's a lot of people who would say, I'm not 100% certain of the tests, and it's easy enough to avoid these agents. So most people would probably deliver a non-triggering anesthetic despite a negative test. And some of the tests, they're looking for certain mutations. We've identified a lot of them, but not every one of them. So you could have the mutation, but still have a test that is negative because we haven't yet discovered that particular mutation that this person has. The mortality of MH is about, according to this slide, it's about 1.4% with treatment. Looking at a different set of data of just the calls that went out to the MH Foundation, you see that there's two very different levels of mortality depending upon where the person triggered, whether it was at a hospital or at an outpatient surgery center. There is a huge disparity. I'm not sure whether it's because they're just not set up the same way, or whether it's because there are still some places where they do surgery, they provide anesthesia, and they do not have dantrolene on the premises. We have it both here and at the SPUB. We have our dantrolene, by the way, in the malignant hyperthermia cart, which is in this room. Does anybody know where it's usually kept when we're not using it to give presentations?
Anesthesia room.
Correct. It's kept in the anesthesia storeroom. It's right next to the refrigerator, and it's plugged into the wall because there's a refrigerator on the bottom of it. Okay. What do we see when someone triggers? Well, there's a lot of signs, but most of these signs are subtle or non-specific, okay? Muscle rigidity, you don't always see. A lot of these patients are intubated with a non-depolarizer, so if you're avoiding the succinylcholine, you're not always going to see that. Increased CO2 production, that is what we see fairly consistent. Rhabdo, we don't look for it, we don't check, and it's not that common. The hyperthermia is a late sign. Even though it's a hallmark of the disease, it's not something that we see early and consistent. And the other signs, tachycardia, acidosis, sometimes hypoxia, these are very non-specific signs. We see this in the OR for a lot of different reasons. So sometimes the diagnosis, at least initially, can be difficult to make. This slide shows the spectrum, and I think it's missing one portion of the spectrum. It says fulminant MH, and this is where it's obvious that's what's going on. You can see masseter spasm predominantly in kids after succinylcholine, and then you can see it happening after they've received their anesthetic. But what they left out is that oftentimes this presents as something that just sort of smolders for a while before they let it. Sometimes the early signs can be subtle, and then they become more prominent, and then you have a fulminant case. This slide demonstrates that there are certain known muscular diseases that are associated with malignant hyperthermia. You don't have to memorize them, but there will be patients coming to us with known MH susceptibility, in which case what we would necessarily do is give them a non-triggering anesthetic, basically by avoiding succinylcholine and volatile agents. Okay, this is the important slide. What do you do if you have a case of malignant hyperthermia? First thing, call for help. Okay, most of us have Voceras. We have the emergency broadcast that can be used to get everybody here who needs to be. Okay. Next, stop the triggering agents. Okay? Most of the time, that's fairly easy and straightforward. If you can also stop the surgery, that's beneficial. And then there is one very specific antidote to that, and that's dantrolene. Okay? It says 2.5 milligrams per kilogram, and repeat, PRN. If you have a 70 kilogram person, that's going to be approximately 200 milligrams. Okay? Each bottle of dantrolene has 20 milligrams, so think 10 bottles. But I'm going to give you another way of thinking about it. You mix up the dantrolene, you give it, and you keep giving it until they get better. Because if they don't get better after 2.5 milligrams per kilo, you're going to repeat it. So this is a fancy way of saying keep giving dantrolene until you break it. Not break the patient, until the episode is triggered. All right? And the rest of it is support. You cool, you treat arrhythmias, and you treat any of the hyperkalemia, the acidosis. All right? Dantrolene is in your MH cart, and I have a bottle here. All right? Do we have any anesthesia students who can tell me? We don't. We do. Aha, Tom.
Trying to highlight.
Tom. Question number 1. What does this have in addition to 20 milligrams of dantrolene?
I don't. I want to say maybe sodium bicarbonate.
No, this has mannitol. Yeah. Every bottle of dantrolene has 3 grams of mannitol. And the other question is, when you reconstitute it, what do you use to reconstitute it?
It's D5.
It's distilled water. Okay? And the important thing is that this has so much stuff in it. This has between the dantrolene and the mannitol. If you use saline or ringers, it'll precipitate. So you have to use sterile water. And that cart, in the cart here, we have 6 boxes of dantrolene, and we also have sterile water. Okay, and this is what you have to use to reconstitute. And you have a bunch of big syringes, and you need a bunch of strong people to reconstitute it. And then, essentially, after the crisis is managed, you keep giving them dantrolene for the next 24 to 48 hours, bring them to the ICU, and monitor for any sort of muscle breakdown, hyperkalemia, acidosis.
Did I miss how much water you need to reconstitute
I believe
one
it's
bottle?
60 mils in a bottle. And we have 60 mil syringes in there. So basically 1 syringe per bottle. Let's see. This slide basically, let's skip over this one. There are 2 tests that can be used to determine who is MH susceptible. The gold standard is considered the caffeine halothane contraction test, and it involves a muscle biopsy. It can only be done in certain centers where they actually do the test, because they need the fresh muscle. You can't biopsy here and ship it off to the Mayo Clinic. And essentially, if you take that muscle and expose it to caffeine and halothane, the muscle will contract if you are MH susceptible. Normal muscle won't. And then there's genetic testing that can be done, but the problem is, again, we haven't identified all of the mutations, just some of them. So if it's positive, that's very telling. If it's negative, it's not. If you have a patient who is known MH susceptible and they're coming to the OR for a case, how do you give an anesthetic without triggering? And there's two things. First of all, you want to avoid giving succinylcholine and volatile agents. And the next thing is you want to make sure that the machine that you use is clean and doesn't have any residual agent in it. So it's just a matter of turning up your flows and basically washing all of the old anesthetic agents out of the machine before you anesthetize. Most people say 20 minutes. There are some published guidelines which say over an hour. So,
What is our guideline? 20
well,
minutes
I would say 20 minutes
here.
here. Yeah.
That 4 minutes eliminated on the machine, the cart, on the other side.
I'm sorry?
This form
Yeah.
has the actual instructions.
Okay.
How to flush it.
What time does it have?
For our machine, if it is not exposed to desflurane, it's 25 minutes.
Okay. Lastly, there is a resource, there is a hotline. If there's any question about whether you have an MH episode or how to manage it, the number is 1-800-MH-HYPER. And it's on the cart there. We also have a print up of the Stanford guidelines on how to manage. It is on the computer and it's also here on the MH card. Okay, this is the guidelines. This is the algorithm of how to manage an episode.
So Glenn, the only thing you might want to add is somebody with MH, you treat it as a code. There's one person in charge and everyone else listens. You have one shot to get this right. When somebody has MH, if you don't get it right, unfortunately you're going to have a death on your hands. So somebody take control and runs the code.
We also have, I'm not sure how to get it on the screen here, but there is an icon for the Stanford guidelines, and it's in there. It can be pulled up, it can be broadcast on every monitor as far as what to do.
Yeah, and the reconstitution of the drug is very, very difficult. It takes a lot of time to draw it up, to mix it. We're looking at there is now a reconstituted dantrolene on the market. It has a much shorter half-life, and no surprise to anybody, I think it's like 5 times more expensive.
Has anybody had an episode of MH?
When I was in Pittsburgh.
I've had somebody trigger also.
And a lot of issues have been on in this patient because this actually was the second time he peaked for 20 season. He was a kid doing like undescended testis, and we do it in 2 stages. So in the second stage, he has a King-Dupont syndrome, which is one of the syndrome that may have association with an MH.
Yeah.
And these patients have to be in ICU after that because that really caused severe muscle weakness, and they have to be intubated. They lie, a lot of electrolyte disturbance, fluid balance, so this has to be in ICU after treatment.
Now I had a different experience. This is somebody who, he also had a previous uneventful anesthetic. And he was intubated without succinylcholine, and we're using isoflurane, and his CO2 was slowly rising over the course of like 20 minutes, with everything else being uneventful. And we were watching and wondering, could this be MH? And then after about 20 or 30 minutes of his CO2 slowly rising, then he got tachycardic and his temperature started to rise, and we treated it as MH. There were 3 people in the room doing nothing but reconstituting dantrolene.
Sometimes.
Yeah.
But you have to wait till the body, the patient itself ends up having to throw up. I don't know.
The heat?
You treat it and everything.
Mhm.
The body responds to it, doesn't get any worse, but the body in itself has to, the muscles have to,
Get rid of the byproducts.
Yeah.
you have to wait for the patient to do that in order for it to be out of the system. That's why they go to the unit and stay on a vent and wait for days.
Right.
Sometimes it's days, a couple of days I've seen it.
It can, yes, it depends on how severe it is and how early you catch it. The case that I had, we brought him to the ICU intubated, and we actually extubated him within an hour of arrival to the ICU. He spent the night there and then went to the floor and did very well. Yeah.
But
He was a
they
young
get
guy.
post-operative dantrolene.
Yeah.
It's not just the one dose. They'll get dantrolene every 4 to 6 hours for a period of time, depending on how severe the reaction is.
Depending, that's why we have to call the MH hotline, because they will tell you exactly when to stop.
Yes.
It depends on the CK levels, and as soon as the ones start to go down, they will stop the dextrolene.
There is a consultant available 24/7
Hotline.
to answer questions about this.
How quickly do you put the dantrolene into the patient? Because it seems like 100 years ago, when we talked about this, they actually were asking, because they were saying there's a lot of people that have to be doing this at the same time, and they were actually told to inject it into a basin so that anesthesia could pull it out of the sterile area in order to, instead of
If,
injecting it into the,
as soon as you got it in the syringe, inject it to the patient.
okay, so you just save the syringes and they use it from the syringe.
Yeah, we would just give it, we would
Uh-uh.
Just say
reconstitute
one
it as a
syringe per vial, so when you're drawing it up, there's enough in there so that if 3 or 4 people are reconstituting it, you just keep giving the anesthesiologist.
So you leave it in the
pulse-
syringe, when
Yes.
you reconstitute it, you leave it in the syringe and you want it, so you only need lots of syringes.
We have a bunch of them in that
Okay.
drawer. Yeah.
What's the refrigerator for?
The refrigerator has basically cooling supplies. Okay? It's got ice packs or cooling packs here and cold saline. These are not cold now, but these you can pack it patient. There is cooled saline that can be either for IV use or gastric lavage.
So there's only 6 bottles of dantrolene in the cart?
There's 6 boxes.
Boxes, oh,
Each.
like boxes.
Yeah, sorry.
Okay, boxes.
Each box is going to have 6, so we have 36 bottles of dantrolene in the cart. And I believe, do we have additional stores in the pharmacy? Yeah.
That's 2.5 milligrams per kilo or 1 milligram per pound. So,
Yeah.
Glenn, did you mention that the highest incidence of MH is with Egyptian anesthesia providers?
Yeah.
You don't want to stay at home.
experience of 16 years and have only 1 patient. Extremely rare, but it's really scary. So it's extremely rare to see someone.
I would venture to say we've probably had more patients than we suspect. Because there's a lot of patients who can get a triggering anesthetic without triggering. And then on their 3rd, their 4th, their 5th anesthetic, they will trigger.
And so everybody's always very busy in the hospital. MH is one of those, I don't want to call it an allergy, but when somebody is identified with MH in the hospital, it's on the upper band in the EMR in red. So that obviously sometimes people miss things, part of a timeout, etc. So you can always find it there.
So given that medicine, you give it bolus,
Yes,
right? Push it
Yes.
as fast as you can.
you get extra people that to reconstitute the dantrolene because there's a lot of bottles and it takes it's not quite as quick as reconstituting ANSEF. You have to really shoot it in there and agitate it, and it takes a few seconds to dissolve.
I guess for the logistics standpoint with the operating room, say what happens to have a weekend in a place like this where it's limited resources, I guess we would call maybe a code or something to the OR. Just trying to think how we would get extra manpower in here.
Yeah, I would call rapid response. I'd do whatever you need to get people here to help out. I mean, as far as the OR personnel here,
Because there's usually, limited,
Yeah.
as you guys say, on the weekends,
Yeah.
there's like
Two ORs
12,
there.
and there's maybe 2 or 3 people.
Great question.
You need more people,
You need more.
And I'm just in the back.
If this happens on the weekend, I would definitely call the nursing supervisor, and I would let Maureen and Tom know that there's an emergency
Yeah.
going on here. The nursing supervisor can get you people.
and yeah, probably would get somebody from the ICU or from some neighboring area to come and help out. It's a good, it's a good question. I'm not really sure. Yeah.
So this should be information that's sent out to the whole hospital in case it ever happens, so nobody's wondering, what's going on? Why, and when is there?
Yeah, but I don't remember the last time we've actually had anybody trigger in the operating room. I think we had somebody at Maine like 10, 15 years.
The guy with the scrotal abscess.
Yeah, that was a while ago. And most of the MH that we see are people who are susceptible, get a non-triggering anesthetic, and do well and go home.
You still treat them with Dantrolene?
No, if
No pre-loading doses or nothing like that?
no.
Because the Dantrolene can make you very weak as well, so
Okay.
you need to be watched after the delivery of it.
Okay.
You know, I think that people need to recognize that depending upon the experience of the people in the room, you know, there's a lot going on. The anesthesia provider has some anxiety, the end-tidal CO2's up, somebody's tachycardic. Is it a light anesthetic? Is something else going on? Is the patient septic? The surgeon's trying to get their job done. And to say stop, we're not sure, takes a lot of guts for people that are in a high-intensity environment like an operating room. So it's really important to have that comfort zone to not have the barriers of communication when you think something has arrived.
And I remember when I had my episode and the patient was getting a little bit, his CO2 was rising, we're turning up the vent, and then his heart rate started to climb a little bit, and we're having a discussion at the head of the bed. Do you think maybe it could be MH? I don't know. The surgeon, leans over the drapes and goes, he's fine, just give him more fentanyl.
Well, right, like on the anesthesia side, you look at other reasons for increasing an end-tidal CO2. Do you have a pulmonary problem? What other mechanisms are there that cause the CO2 to rise? And when CO2 rises, commonly you get a tachycardia. So you have to have an index of suspicion in terms of the whole cadre of things that are going on.
Questions? Comments?
I have a question. On the screen that comes up, kind of delegating what we're doing, either if you pull up the Stanford thing or if you're on the phone with an NH person, I guess maybe for a practical standpoint, and Diane, I don't know if this is what you're going to plan to do next, is to go over maybe some who does what, like practical role play. Patient might just be, they might not have a Foley catheter with a temperature monitor. We need to get that going. Things like that, maybe for practical purposes. Who's going to do what? Because it is going to be a panicked situation. It's going to be crazy. There's going to be a lot of people. And yes, anesthesia's in charge, but we're focusing on the Dantrolene and possibly intubating if they're not intubated already. So delegating who would be in charge of the other things. Having someone on standby to run the labs, because we'll be running a lot of labs. Having lab alerted that we will be sending them critical emergency labs. Things along that line.
I can work with Dave to put together an algorithm for that.
There might already be one.
Yes.
Yeah, I'm not aware of a specific algorithm of who does what.
Right.
We can take care of that.
I think that's a good point. I mean, obviously, if it's during the day and there's other ORs going, if an OR is down in another room, and someone has an MH situation, you don't start the other operating room. You make sure there's enough help available. You know, and that in itself has political implications to the surgeons. You know, when somebody's unstable in one room because they're bleeding, you're not stopping the room. But a situation like this, when you know that the outcome is, you know, a high probability of being terribly dismal, you have to function as a team and have the guts to, who's ever running the OR, to say, we're not starting that next room.
All right, thank you all.
Please, everybody, before you go, there's a sign-in sheet over here. If you would sign that, please.
That was very good.
Thank you.
Thanks very much.
Pushing me around.